Thank you so much. And this is the anchor leg on our final formal presentation before the breakouts. We have a great panel who's with us. First off, illustrious co-chair, Dr. Agwu will be with us. Dr. Green is hanging around. Thank you. I'd like to introduce Dr. Jim Raper. A lot of you know Dr. Raper. I've worked with him for 35 years, going back to giving amphotericin B infusions in the emergency room in 1984 and 1985. He's now the director of the UAB 1917 clinic. We also have back with us Dr. Roger Bedimo, who you heard this morning, and Dr. Judith Currier, who gave the lecture yesterday on new drugs. Thank you. Welcome back. And our other co-chair, Dr. Cheever. So with that, I'm going to share my screen and we will get started. It's the usual thing that we've done before. Let me kick this into presentation mode. Okay, there we are. So these are actual cases that I hear over the course of a year or two about what's current thinking is, and I've thrown in a couple of extras just to make it a little interesting. These are my conflicts, basically grant support from Gilead and Vive, no other commercial interactions. We're going to go over elite controller, initial therapy, elite controllers, weight gain, low level of viremia, and distinguishing that from blips, discordant CD4 counts, and picking up on where we just left off, aging. So what initial regimen should I prescribe? And this is how I'm going to orient, just so we know kind of what game we're playing, whether it's soccer, football, baseball, whatever. So this is where we're going to start off. Got a 48-year-old guy presents with newly diagnosed HIV, is asymptomatic, CD4 count is 65, viral load is over 300, around 300,000. Other labs are normal, genotype is wild type, no prior medical history, normal renal function, HBV immune, is okay to start therapy. Before we get into this, I've got a practical question of, is there any additional lab test here you might order? So these are the points. There could be more than one correct answer. Go ahead and vote. Oh, Appalachian Spring. Oh, good. Actually, something I recognize on the elevator. How many floors are we going to? Just past floor number 19. I think you can see how people voted. Thank you. So a lot of folks went to the B5701 panel. Anybody have thoughts on what you might get, if anything, at this point?
I would concur with number 3.
Okay. And that's going to be if we use abacavir. How about a integrase inhibitor genotype? Anybody feel good about that? Dr. Currier, would you order that?
You know, that's done quite frequently. I think I got stumped on this question last year, and I think the right answer was the cryptoantigen, which I hadn't realized had been added to the OI guidelines, but you educated me in a panel just like this about a year ago. So I think that was the practice of, doing genotype when in areas where the rates of resistance are low is really evolving. I know we still do it often in our clinic because you have one experience where someone actually ends up not responding to first-line integrase inhibitor therapy and develops resistance, but I don't think it's generally widely recommended anymore to be done.
Yeah, exactly. So in the interest of time, I'll just kind of work through each answer quickly. Integrase inhibitors only if your site or your region is experiencing really more than 1% baseline integrase inhibitor resistance. You're going to say, well, how do I know that? Well, typically, unless it's tested for, you won't know, but you'll start seeing failures, and we aren't seeing that. So that's generally a very specialized thing that's localized. Toxo antibody we used to get all the time back in the day when we saw a lot of toxo, and we kept it on record in case they deteriorated. But people starting on antiretroviral therapy today, usually, unless they have symptoms of toxo and a mass lesion, it's not really all that helpful. As Dr. Raper said, the B5701, if you're going to use abacavir, we're tending to lean away from using that. There'll be a question coming up here on abacavir in just a minute. I'll skip crypto for a minute. Urine histoantigen only if you're in an area that is very endemic for histo and the patient has symptoms. But your serum crypto, we are starting to see more and more cases around the world, especially in sub-Saharan Africa, but even in the United States, where people have baseline crypto antigen positive, which means they have pulmonary disease at a minimum, and it may be asymptomatic. And then next thing you'll do if it's positive is a lumbar puncture. And in that setting, if it's negative, you'd still go ahead and treat them for the crypto in their blood and perhaps lung to start with, and that'll prevent them from getting meningitis. And the recent IAS-USA guidelines in 2020 did recommend this. As you can see here, if the CD4 count was less than 100, this guy's test was 65, that go ahead, it's cost effective. The test is inexpensive, and the benefit, even if you just turn up, say 1 in 100 people in this setting, is it's cost effective. So good memory, Dr. Currier, and that's why I brought it back, because I think the penetration of this knowledge is a little low at the point. Okay, well, let's get now into the antiretroviral therapy. So on the right-hand side, I've reminded you of the profile of this patient. Refresh your memory, and let's go ahead and vote and see if we can have other recognizable music in the background. I recognize this music from a Harold Pinter play. It's called Silence. And it's some sort of cosmic lullaby. Let's go ahead and see how folks voted. Ooh, with a bullet, single tablet regimen. We'll come back to that. Anybody on the panel want to support some of the other options here before we just jump into the obvious? Another Pinter pause. Allison, you want to try to give us some balance in this presentation and not just go with one answer?
So sure. I mean, I think I would go with number 4, the TAF-FTC BIC. You know, that was what I would choose. I would choose it over number 3. I feel like it's more potent. I wouldn't want to put him on a protease inhibitor just because I think we could go with entities and for a reason. You know, one could debate he's 48. He's not, I have to be careful because now I'm 47, so I have to be careful. Say he's getting up in age. One could say, could you do a 2-drug regimen? But I think I would agree with the audience that number 4 would be where I'd go.
Okay, we certainly are using a lot.
Yeah, I think that more and more data accumulating that 2-drug regimen, dolutegravir and 3TC, is not only robust but rather durable. So people will gain more and more confidence on 2-drug regimen, especially this patient has a viral load of less than 500,000 that used in the initial studies.
Even used as initial therapy, and I'll show some data that just came out on Friday, I think, in just a second. I think we're leaning away from anything that requires boosting, so I think that takes answers 3 and 6 out. And then what about a 2-drug regimen? Is it there somewhere? Yeah, number 2. Anybody prefer that over the single tablet? Is there a situation where you might use TAF-FTC with dolutegravir as a?
And I think the only place I could always mention, I take care of adolescents, and sometimes just that tiny dolutegravir pill that people get so excited about, and it can, you know, push adherence for whatever reason. But otherwise, I don't see why you would necessarily do. Right.
And so I think people, the audience in particular as well, has gone for answer 4. And a lot of times it's beneficial because we're trying to get people treated as early as possible. The question came up yesterday to Dr. Cheever about, well, we'd like to start people in the ER. And that's a good drug because you don't have to worry about the Hep B, the resistance isn't an issue so much, and that type of thing. Dr. Raper, you have, you've had experience in the ER as a director way back when. What's your opinion about somebody, we screen in our ER, I know a lot of you do as well, somebody tests positive, Jim, what's your opinion about just starting right on the spot as opposed to making a referral and getting them seen in a couple days?
Well, my experience in working in the emergency department is a lot of people in the emergency department have no connection with healthcare. And when you take somebody with HIV, new diagnosis, and you start treatment on them without really assessing their ability to be engaged into care, I think you're taking a really big gamble, and I really don't see what the downside of waiting until the patient can get enrolled in care and prove evidence that they're willing to be engaged in care. I don't see the time difference being significant.
Anybody want to present a counter view?
Yeah, so I will a little bit.
Go ahead, Allison.
Yeah, no, I think, certainly I'm old enough to remember the days where we used to tell people, oh, you're tested positive, but your CD4 is 500. Let's wait for it to go, whatever. And people, out of sight, out of mind, and lost that urgency. And so I think, I completely hear Dr. Draper's point about wanting to get some understanding of where people are. But I think that's a systems issue, and could we design things, at our institution, we have literally a rapid start BAT team that they gets to the ER, they literally get the patients, all their contact information, et cetera, and gets them started ASAP. So I think there's a way to do both, right?
Yeah.
Yeah, and I was also going to say, I completely agree with Dr. Raper's, thoughts about it. But when people have tried to study this in randomized studies, the people who get started right away do better, and in different settings in different countries in the US and with pretty hard endpoints. And so when the data says that it's beneficial, but our beliefs are that it won't work, how do we reconcile that? And I think maybe looking for local ways to bolster it up to make us comfortable is the answer.
Well, there's no question in sub-Saharan Africa, when people were having to travel a long way to get to the ER in the first place, there's no question there's benefit there. The question that I had in my mind as I saw the studies from the US that you've alluded to, Judy, is there's a whole team. There's a study team, right? And they descend on it like the movie Brazil, when the people came out of the ceiling and landed at the bedside, if you ever saw that movie. And so you have paid people who do nothing but come in and visit and make the patients feel even more special. We're in a crowded ER, especially in the era of COVID. Things are helter-skelter there right now. I think it's a balancing act, but this is why I asked the question, because we don't have a firm answer. I think what's critical, and Allison, you pointed this out, that 10 years ago, we were waiting for CD4 counts, for goodness sake. And we had people going for years without being treated when they should have been. A couple days wait, as long as we're in contact with them, I don't think is a huge amount of harm.
Right.
And I think it's an individual site, and as you said, systems question. If there's a way to do it, great, and monitor the results. Jim and I work in Birmingham, obviously, together, and we're finding that our show rate is really pretty good. Well over 80%, 85% when people are diagnosed in the ER, they do keep their appointments. And then once they're engaged in the system, they tend to stick. But I think a common big picture issue is the longer you wait from the time of diagnosis, the less likely they're going to show up. So you really want to get it done in that first week. So early for sure, immediate, I think it depends, right?
I know rapid is less than 7. It depends on what study you look at, right? The window, is it immediate is less than 48, is less than 7, less than 14. So I think you're right. It's balancing what is feasible for you in your setting.
Well, what's nice about, go ahead, please.
I just would also throw in what you've got to a little bit earlier, Mike, is the cost effectiveness of it. So if you have limited resources and you're going to deploy them to engage people you haven't yet engaged in care, you don't have unlimited resources. No one does in this arena. So it's really trying to figure out what that sweet point is. If it is getting someone in the next day or within 2 days versus actually starting them in the ER, compared to spending your money in other ways. I think Jim Raper is going to talk about some of those other things you should be doing to engage people that aren't engaged. So I do think that we need to consider that, and those studies usually don't.
Okay. Good point.
Good point. Well, Dr. Bedimo mentioned something, and I pulled some slides from the last meeting. So these this is the earlier study from dolutegravir 3TC, but it was not, these were studies not at the time of presentation. These are a little bit different, the earlier studies. And as Roger just pointed out, there at the ID week, there was 144-week data that showed it basically was maintaining its activity comparable or virtually identical to the dolutegravir combo. But what we saw also this past week was a study out of ViiV where they took patients that were showing up newly diagnosed and starting them immediately on dolutegravir 3TC. And the key thing over here, if you notice, is that they if people came in, started on it, but then later were found to have renal, some degree of renal disease, or any grade 3-4 lab abnormality, or if they were found to have hepatitis B surface antigen, et cetera, or if there's resistance profile came in, they switched them. But it was an idea to see how much that could do. And one of the things that has been associated with dolutegravir 3TC because of the early studies was not to use it if the viral load was above 500,000. And these data that just came out, it's a little bit complicated here, but it depends on what analysis you use. So observed means that the people who dropped out are not counted, so it looks good there. And then if they missed their visit when they were supposed to get the viral load measured, then they were counted as failure, and the snapshot is even more stringent. But the take-home point is that it did seem to work, and even in the strata, there were, not a huge number, but on the order of about 100 patients. If you use that missing data, you saw about 10 to 11% people who were failures. But if you take that same cohort and now allow the missing data in, it was 100%, even when it's greater than 1 million. So Roger, I'll start with you and maybe get others to comment, but how do these data, this has face validity to you, or you have concerns?
Yeah, there were a number of concerns with initial therapy with dolutegravir 3TC or any dual agent. The first one is theoretical from our history of 2.5 decades of triple therapy is it potent enough? Do we suppress the virus enough with just 2 drugs? So viral kinetic studies have been done to suggest that we probably have as robust a suppression of virus with this one. Another concern had been because the initial study having a cutoff of 500,000 viral load, as whether this is going to work with more than, greater than that. And maybe this data is making us a lot more, maybe a little more comfortable with people with baseline viremias that are this high. And the initial analysis also had suggested that a CD4 count of less than 200 resulted in a low efficacy, but that probably, it depends on the analysis that it did, that did not really show that this was, a higher rate of confirmed virologic failure for those. And then other concerns, as you said, that were kind of alluded to in the start, where what about somebody who's co-infected hepatitis B, and then you only discover that later? It's very likely that this is not long enough exposure of the hepatitis B to monotherapy with 3TC to lead to YMDD or other mutations. So I think that you have time to stop and change. So for all these reasons, I think that we probably should gain a little more confidence in dual therapy.
Other comments from others?
What about the pre-existence of an M184V, that would not be detected early on? I think in our location, we have about a 15% pre-existing resistance.
Right. And so if going back, if they did test them, in other words, they would be started on this regimen, the test would come back. If they saw an M184V, they would take them off. And that's how they manage that. I'm trying to do the math here, but it looks like about 20 people were taken off for either they had Hep B or they had a M184V at baseline. And Jim, are you referring to more of an occult M184V that isn't detected?
Well, one that would be detected if they had their resistance assay,
Right.
but oftentimes, they could potentially get started on this and they may not come to the clinic for another month.
Yeah.
And at that time, the resistance assay would be ordered, and it would be another month after that before the resistance assay were back. So effectively, they could be on a monotherapy with dolutegravir for 2 months.
Right. And so in this study, I don't know the time between initiation and change in that setting that you described. You would want to get that earlier. And I think you just have to it's an extra burden that, again, a study would make up for because people are getting paid to watch very carefully. And so it's in the real world, it would be important to bird dog that, like you're saying.
Yeah, can I just add one other thing? I think just doing this the other way around, I mean, with the 3 drugs to start and then backing down to 2 once you
Little bit.
have the information, and you wonder if the same manufacturer made the pill that had 3 and 2, if they wouldn't have designed it that way.
Yes, indeed. Yep. That's why we're having the discussion.
Yeah, that was gonna be my comment too.
Okay, so this is how we take data that comes at us and digest it. So this is exactly the discussion I wanted to have. Thank you very much. All right, so Judy, now we go back to your talk from yesterday. Those of you who didn't hear it, I thought it was fabulous. But we're going to just sort of take our same guy, the 48-year-old guy, except now we're 2 to 3 years down the road. And we have our top 2 regimens there, but now also we have cabotegravir, let's assume with rilpivirine can be given every 8 weeks IM, or islatravir with lenacapavir, maybe with an implant at 6 months or a year, or you didn't talk as much about monoclonal neutralizing antibodies, but maybe with something else or some other option. Let's go ahead and vote and see what kind of music we get this time. Down by the riverside that appears to be a combination of Lawrence Welk and can't quite decide if Al Hurt maybe in New Orleans. It's a weird mix, which is a lot of these drug choices are weird mixes. All right, Judy, this is all yours. So now we couldn't ask you this yesterday, but I was really pleased to see you on the panel. So what's your best crystal ball prediction and what do you think will be the hot agents?
Yeah, I don't know. I think it's very hard to predict. I don't see, I mean, I think a symmetric regimen for long acting is probably, going to have the biggest impact. And if you really could have an implant with the islatravir and lenacapavir that was given once a year, that would be great. But it's just very early to predict whether that's even going to be feasible, let alone effective, especially as an initial therapy. So I think it's very hard to, I mean, I think that cabotegravir, rilpivirine every 8 weeks will certainly be an option, but maybe by 3 years from now, we could have things that would have a longer interval. And maybe it would include a long-acting BNAB with islatravir implant or lenacapavir implant, but
yeah,
I don't know.
How about,
I guess the point of discussing it is to say things are evolving and keep an eye on it.
that's right. And it sort of still goes back almost to this notion of the I'll call it bias. It's a little something different than that, but when people participate in the study, their motivation is different than somebody who's just being asked to take some intervention in practice. So it's efficacy versus effectiveness kind of issues. And the second thing is, again, you have a study team who is really on top of it. So maybe Jim, if you don't mind commenting, we've had some discussions about how to implement, if we, when it comes out and available to us, the injections every 4 weeks is going to be really challenging. But let's just say every 8 weeks. You direct a clinic. What are your thoughts about this?
Well, so, thank you for asking, Dr. Saag. The implementation, the administration, implementation burden of getting cabotegravir rilpivirine off the ground is tremendous. The white bag versus the buy and bill options, neither one of them are particularly exciting. And knowing each provider, each insurance provider gets to determine which particular type of drug acquisition reimbursement activity is going to take place makes it even more challenging. And then dealing with some of the insurance providers and their unwillingness to necessarily, make this a transparent system. At least in Alabama, we don't even know what their prior authorization is going to look like for this particular medication. So, while we've got several patients on the 4-week and the 8-week arms of the cabotegravir rilpivirine study, we are certainly not in a position at this point, I'm not, to forecast the future.
Yeah. So I think I was trying to be a little bit thoughtful about the three other options that I listed here. Each of them requires some effort on the part of the clinic to organize. So even if it's an implant, they got to come in to have a small surgical procedure once a year, perhaps. Not a big deal on one hand, but on the other hand, it's something new. And the monoclonal antibodies or the BNAbs, that's going to require an infusion. But here's a question I don't know if you all thought about. There feels to me to be a difference writing a prescription and handing it or emailing it to a pharmacy, and then you're done, right? When we do something active, like an injection or an implant or an administration, and a patient misses their return visit for something we actively did, are we responsible for bird dogging that and getting them back into the clinic? Is that now our responsibility? Whereas if somebody misses a visit, they still pretty much get their medicines delivered and we don't think about it so much. Have you all thought about that?
No, I think I spent, sorry.
No, go ahead.
I spent a lot of time thinking about this. I mean, I think, certainly it's sort of the same way you prescribe depot, and that's what you're doing. And we're developing all kinds of systems to try to make sure people come back in for their appointment, reminders, et cetera. So I think this is sort of the same thing. Our plan is to give people a shot, and how do we maintain that? What's the systems we have in place? I will say, just to step back a little bit, what was exciting about this list is, wow, look at where we are. The last conversation we had last case was, well, what should you start first in this guy? Would this be it? Realities and rapid start versus not. I mean, I can imagine a time where someone is in the ED and this is the intervention they can make, is get them started on cabotegravir. So while they're waiting to get in, whatever that delay is, where they're not viremic, et cetera, and then you're getting them. So I think there's ways that we may think about this, and the patient perspective as well is going to be critically important, because not everybody's going to want a shot, but some people may want that shot, particularly in that critical period.
Right. Thanks. This is the future, and I don't want to dwell on it all, but I did want to raise the issue. So here's something that comes up a lot. I know Dr. Raper and I follow a couple of what we would consider elite controllers. So here's an example of a 30-year-old guy who was diagnosed 7 years ago, was asymptomatic. The viral load at baseline was less than 50, and CD4 count was almost normal. So we check a HIV DNA and it's positive. So sure enough, infected, as we say. These other labs were done. But the question is, in today's world, several years ago, we might not have started therapy. What's the current thinking on an elite controller today who comes in newly diagnosed? Go ahead and vote. Would you start therapy? I think the Nirvana bassist has just left and formed Elevator Music Company. Okay, so the majority would actually start therapy. Personally, I agree with that. Anybody would say no, wouldn't do it right now?
Well, this is Laura. I leave it up to the patient. I go over the data, including increased hospitalizations. I make the recommendation that I would start, but I don't sit on them the way I would with a person who had a detectable viral load.
Yeah.
But I do have that discussion. I have a patient who is in the ER more than he's in ever to see me. And unfortunately, he also has bad hepatitis B, so, or high level hepatitis B with some fibrosis. So with lots of reasons to be on medication, but I do leave it up to the patient.
Yeah. And in the interest of time, I'll just jump ahead to partly of at least my rationale that these are relative. This is Peter Hunt data from California. This is looking at activated CD8 cells, and you can see untreated patients are here, treated patients are here, and HIV negative. So even the treated patients have got some degree of increased activation. And more specifically, when you look at those treated patients' activation here versus negative, the elite controllers are somewhere between the two. And I look at that as almost the price that the immune system is paying to keep the virus suppressed. So, it's like a duck on the water. They often describe students at Stanford that way. They're quiet on the outside, but underneath there's churning, the feet are moving. And that, I think, is what the immune system's doing here. And the question is, will that have impact? Without mentioning names, Jim and I have a patient who just came in with her early 50s with chest pain that sounds a lot like angina. She's been an elite controller for 20 years. And as we left to send her for her MIBI, I wondered to myself, did we do a disservice? It's an N of 1, but the data sort of suggests, but Laura, I like your suggestion. We have more and more data that suggests this. I just wanted to put it out there to say that it feels like we're moving towards this. And another thing to think about, and maybe Judy, you can comment on this, is that as we haven't been able to cure HIV like we do hepatitis C, we just get rid of it. A lot of people have switched to, quote, functional cure, which to me is basically establishing the status of an elite controller. And I'm not sure that's good enough. What are your thoughts as the leader of the ACTG?
Yeah, I think this price of control is really the issue. There are off-target effects from the immune system controlling HIV that are important. And, I think that the jury is still out. And I agree that this is a discussion you have to have with the patient about what we know and don't know about the long-term effects. I wonder too about, I like to say, with thinking about HIV cure, you can't stop if you don't ever start. And so, maybe there's some benefit to reducing the size of the reservoir, priming someone for later cure interventions if they go on treatment, kind of containing things. But we really don't know. I haven't seen any sort of long-term survival data that suggests that elite controllers don't live as long, or so this is really still, I think, a theoretical concern, but I think that people are moving towards treating.
Agree. All right, well, perfect. That's the discussion I hope we'd have. So great. So we only have about 13 or 14 minutes. I want to get to some more topics. So Dr. Bedimo, this is teed up for you. Patients started 12 months ago on single dose regimen. Initial viral load was 28,000, CD4 was 450. Now great control, but her weight went up pretty significantly from about 26 pounds. And what are you going to do? Here are your options, sort of a George Herbert Walker Bush, stay the course, change wouldn't be prudent, or something else. Go ahead and vote. It's almost like Steely Dan has moved to the elevator now. Got that little twang in. Okay, let's see what we got. All right, most people would stay the course, change wouldn't be prudent. There's all kinds of other options, including, interestingly, an ACTG study that I think Dr. Bedimo knows something about. Roger, you want to take this one?
Yes, thank you. And most people are not certain that a switch will result in a meaningful weight loss and attendant metabolic benefits. And I do agree that we're eagerly awaiting ACG 5391. Unfortunately, I think Judith has talked about it a lot better than me, enrolling a little slowly, but this is important to know that the reversibility of the weight gain on antiretroviral therapy is not guaranteed. We have a lot of case reports, both in PrEP and in antiretroviral therapy, suggesting that switch from away from TAF and or INSTIs had resulted in significant weight loss. So TDF, FTC, not only is that they've been associated with less weight gain, but probably weight loss. Again, in one study in ID week this week suggesting as much, and doravirine has not been associated with as much weight gain, especially being a non-nuke.
So the question, yeah. So the question is basically for the bottom line is we don't really understand why any of this happens, and it's really hard to prescribe interventions when we don't know this. I think the ACTG study will hopefully address some of the question. If I had to put a nickel down, I would guess maybe that there isn't going to be much difference, but we'll see. That's why we do the study.
Yeah.
Yeah.
So one thing that is interesting to point out to patients before they start antiretroviral therapy is that this might occur and that we don't have good predictors. She's in the bad demographic, which also had a very low viral load and very high CD4 and relative high CD4 at baseline. Those two things predict less likelihood of weight gain, but she did gain a lot of weight.
And that was presented somewhat this week as well at the ID week.
I do think that we do, as a profession, need to do a better job talking about diet and exercise regularly, routinely with our patients. So, even before. So, you hear from her when you're starting that, well, this is her diet, and it's clearly one that contributes to weight gain. I think addressing that before you get on.
Yeah, I think that's a new change that we're making, right? As we prescribe the therapies to say, watch out.
Right.
This is a good time to kind of keep an eye on your weight and exercise and that type of thing.
Yeah, and if I can just add a comment, I think I'm just struck like across all of these cases, I think it's really, the discussion with the person in front of you, and it's really individualized. And I think that's going to be even more important as people are aging with HIV too, and you're trying to consider all the pros and cons, and that it's really the non-pharmacologic things that we should find ways to emphasize.
So I think I'm going to just skip through this case. It was basically a question of somebody with high cardiac risk factors who comes to you on an abacavir-based regimen, has not had a heart attack. But basically the question is, do you keep the abacavir or do you switch to something else? And to save time, just thoughts from the panel, would you switch this patient? Yes, no? You get them off abacavir, or would you continue? They're on atorvastatin, got an aspirin going. If you think that's, the abacavir has been putatively associated with the platelet aggregation issue. So that's one thing. I think the bottom line is we don't know.
And we'll never know for sure, but we'll see.
Yeah, we don't know.
Yeah,
But
and I think as Meredith said, it's a discussion with the patient. I think it's always good to let people know about new developments and new options that are available, but it always strikes me how reluctant people can be to make any changes, especially if their viral suppression was sort of hard fought, and tenuous. You have to have a really good reason to change for them to want to change. So you need to understand what their perspective is.
yeah, and the other,
I think that's particularly true too, Dr. Saag, with the alternatives to a abacavir containing regimen.
yeah, that's right. And the other thing, sometimes we so focus on the drug that we forget to say, oh yeah, the smoking might be a big deal here, which it is, right? Okay. I want to get to these cases because they're a little bit more common. So we have somebody that's persistently detectable viremia. So basically a person came in pretty advanced infection, then got on treatment and the viral load came down, the CD4 went up, but we never got less than 50, certainly didn't get anywhere close to less than 25, had been through a bunch of regimens, now is on a dolutegravir, darunavir, 3TC and doing well, tolerating it, and has the values as you saw. But the viral load is still detectable. Would you change? Yes, no, not sure. Let's vote. Those of you who are wondering why we have such music, it's because you can't put this on YouTube with copyrighted music. So we're going to want this to be available, so we suffer through some elevator stuff. Okay, most people stay the course. Change wouldn't be prudent. Panel?
Yeah, it sounds like this has gone on over a long period. I kind of missed the time frame here. Is this somebody who
Yeah,
just got,
it's been at least 4 years, and
Yes.
yeah, and it's never gotten down.
and never like, so it's
But
below
has stayed less than
200
100.
or?
Right, never went less than 50. Even if it did, it was maybe 45.
Did you say anything about a CD4 count, Mike?
Yeah, it started off real low. It started off real low at 70, went up to 525, and the value never really went down. It's 18 years. So this has been going on for a while. Yeah, sorry.
Sorry to
So-
interrupt you, Judy. Go ahead.
No, go ahead.
Yeah, most people would, and I just wanted to make the point that in this not so complicated, you have cells that produce virus and they infect other cells, and this happens in the order of about a day. You give antiretroviral therapy, you block that. So the question is this a failure of the block? And the answer to this is almost certainly no. The block is just fine. And what we're left with are these residual infected cells in a large reservoir that's even on the order of larger because of the high viral load at baseline. And those cells up here in the upper right corner just spit out virus every now and then, and that's what you're detecting. And so changing therapy would only affect this. It has nothing to do with the cells that are already infected and long-lived. So the question is there breakthrough? And if there was, especially over 18 years, you'd see emergence of resistance if there was de novo replication going on. And I think we're pretty comfortable with that, but it is a question that comes up. But getting to this next case, same kind of story, except this time the guy had a higher viral load, low CD4 count 2 years ago, starting this, got undetectable, got less than 50 for sure, maybe let's say less than 20. And then 4 months ago has a viral load of 91, and then you recheck it and it's gone up some more. And last week you checked it, it's 220. What is going on? And this guy who's claims full adherence and never missed a dose, which is really credible when you know this guy. What do you think is the cause? Intermittent adherence, occult drug use that causes some recent initiation of a multivitamin, de novo resistance that now is emerging, or interference with the Russian bot? Go ahead and vote. The Russian bot wrote this music that you're now listening to. Maybe you got a vaccine or something. Let's see what folks say. You were listening. You were listening to Jen Kaiser. Yeah, this is a real world case that the guy had just started a multivitamin that contained pretty high levels of divalent cation, and he came off. We took him off of that, and his viral load is now nicely resuppressed. He has obviously no resistance because that wouldn't have happened. But I thought I'd just share that case, and we have about 3 minutes left, but so I don't know that we need panel commentary. It just was fascinating, and I still wonder about the bot, but oh well. Okay, this is a very common problem I wanted to have some discussion about. A patient who started on this regimen with Kobe 3 years ago, and CD4 count was 80, and even after 3 years, the CD4 count has not crossed 200. So what is going on, and what are you going to do about that? Would you continue her therapy, or would you switch to something else? You've got a wide range here. Let's go ahead and vote. Back down by the riverside. I guess it's a question of which river. It's like a revival. Okay, let's see how we voted. All right, wildly in favor of keeping it. Anybody want to comment on this?
It's just a very old question. I think ever since the beginning, after therapy with, I think, SP and Silka trying to boost CD4 count in these people, I think really works. And with up to mega art adding drugs and didn't change anything. I think I would agree with the majority in keeping antiretroviral therapy. The predictors of this so-called discordant are difficult to come up. They tend to be older people, sometimes co-infections. So history of OIs. The good news is that with complete virologic suppression, even in this low CD4 count, the risk of OIs have been very limited. If
Yeah.
Yeah,
Well,
I just had a
only
really
oh,
interesting, oh, go ahead.
And no, I was going to say, was that a Darunavir-based regimen? I just want to make
No,
sure.
no, that was 3-drug. It was a cobicistat boosted Darunavir.
Right. So I guess the only thing is why that? Can we make it easier on her life by putting something
Yeah.
smaller?
I think
Yeah, just
the question's more of a biologic one.
right. No, I get that.
It would happen with any regimen, frankly.
Yeah, no, I get that.
Yeah.
Thinking.
So what I wanted to show was this. So the ideal is when you start treatment and the viral load goes down and the CD4 count bumps. And that happens 85, 90% of the time. But there is a situation where you start it and the viral load doesn't budge, which is this case. And what I wanted to point out is that if you track the rise in CD4 count after that initial 6 to 8 weeks, the slope is very similar. So most of the gain is in this first time period. And the thinking is that when you have especially high level viral load and high level replication in lymphatic tissue, there's elaboration of ICAM, VCAM, other adhesion molecules that trap CD4 cells and other cells that when we stop almost abruptly that replication, the elaboration of those adhesion molecules drops dramatically and cells are released. And it's not just CD4 that goes up, the CD8s go up proportionately as well. So it's all lymphocytes, it's not just CD4. And the people that have got perhaps damaged lymphoid architecture, et cetera, they don't get that bump. And there's nothing you can do that I know of that can cause, and at the end of the day, here's the culprit, it's the virus, right? You've suppressed that. How many people do you see with a CD4 count less than 50 a year out who develops CMV retinitis or MAC, right? Doesn't happen because the viral load is suppressed, right? You're right, Roger, it's an old question. I bring it around now and then. I think I pulled this from 2017 because we hadn't talked about it in a while and there's new providers, but I still get this question, especially among the newer providers, why we should change therapy. No, you shouldn't. So I want to
just make a quick comment? Because I just got this question a couple weeks ago and it was
There you go.
somebody just like this and they needed a hip replacement and the surgeons were saying not unless the CD4 count is above 200 and the provider said, I heard lenacapavir increases CD4 count. Should we try to use that because it's a new drug? And the issue is, yes, it did increase CD4 count, but in people who weren't virally suppressed, who had low CD4s and then got treated, it doesn't have any magical CD4 raising properties. But I thought that was sort of a contemporary twist to this exact question. We don't have anything new for this problem.
Well, it's biology, and we would need to explain that to the orthopods, and that can't stop that, Jose. It can be done. Okay, I want to get to this. We're bleeding into the Q&A. I'm sorry, I'll answer the questions, but I want to make sure we get to this for Dr. Green because she did such a marvelous job, but I'm trying to see how we're going to implement this in our practice. So 60-year-old guy, 17 years ago diagnosed, done well, really stable, no problems. Now, is it important to assess the cognitive function for a 60-year-old? And if you do it, how often would you do that? Report of symptoms, routine assessments, every other year, every year? Just start with the question, how's your thinking? Let's go ahead and vote and we'll get Dr. Green's input on this. This is a memory test for me because I can't remember if we've actually heard this music earlier or not. Okay. Take it away, Meredith. What do you think?
Sorry, I was muted. And can I see the poll? It looked like a pretty good breakdown of the responses.
It's mostly based on symptoms. Some people said it should be conducted annually. And those are the two majority. That was 90% of the votes roughly. Either assess it or do it based on symptoms.
Right. So, I mean, I think the discussion here is this is still controversial. And I think, I'm thinking of this is in the IAS guidelines, right, about assessing cognition, I think beginning at age 60. I will say that, so the pros for doing it regularly are that you have a sense of someone's baseline, so that if they come to you in 5 years with a concern, you're able to go back and compare to past testing or see a change. So there, I do say there is some benefit for routine assessments. I don't know that we have data to support how often. Certainly more than annually. I mean, the shortest interval I would do is 6 months, but that's in somebody when you're following their symptoms.
Right.
I wouldn't do it for routine screening that often.
Right.
I think
Or-
annually is reasonable.
What are you doing in your practice?
Yeah, so I mean, as a consultant, a lot of people come to me with cognitive concerns. So that's a separate
Different issue.
question.
Right.
So I think determining the issue of asymptomatic versus symptomatic. Someone's coming with symptoms, you should do something. And if you're doing it routinely, which we've talked a lot about, right now we are not, but we have talked about doing that. And I think we would do it for, I don't know that we would do it for everyone 50 and older. One, because of practicality, that's, more than 1,500 people. But I do think as people get into older ages, because that's when you would start doing it kind of more in the general population as well. Although
Yeah.
there's still no clear guidance on routine doing that in the general population.
My impression is that the general population isn't doing this.
Right.
And that's to me a failure of ours as treating older people, which at least I'm getting closer to that age. So I can't remember what the songs I just heard. But let's finish with this question about performing a frailty assessment. Do you do it at all? Do you do it when a patient falls or maybe frail? Let's go ahead and vote on this real quick, and then that'll wrap us up. Somehow I'm imaging a sagebrush blowing across a desert road somewhere. Okay. Maybe that's when we become frail, when we become the sagebrush. Again, Meredith, I'll turn to you and then see what the general panel says. But are you doing that in your practice yet? For, let's say, somebody 65 having to do sit, stand, or a short walk?
Yeah, this we're actively working on standardizing for more, because I think, again, I think I think it is easier to intervene earlier, and you can sometimes detect subtle deficits. So somebody who's starting to have trouble, if you intervene earlier, you may be able to have more success.
Yeah. And that intervention might be what? Training, personal trainers, or group training, or physical therapy? What would you do?
Yeah, so depending on what you observe. So like if you're looking at gait and, getting out of a chair, if, it is a good sense of muscle strength. So it might mean that somebody needs some exercise. And so depending if there's like a specific gait abnormality or if they've fallen, like I absolutely go straight to physical therapy. Yeah. I sometimes give people the option. Do they want one-on-one? Do they want group? What kind of exercise are they already doing? Can you start with slow modifications to that? So again, I think especially as people get older and they have a lot going on, you really have to take this more individualized approach. That's why I made that comment about even with ART. I think It's just each person's going to need a slightly different treatment plan.
Right. Other comments from the panel?
I like to do the chair stands when I talk to people about exercise. It's sort of a good way to have, without saying I'm going to assess your frailty, but just let's see how you do trying to stand up without using your hands. And then that's sort of like, well, maybe we need to work on that with, with
That's
even
a
just
wonderful suggestion. Yeah.
walking.
Yeah, that's,
can all hopefully walk a little bit.
Yeah, and I think to Dr. Currier's point, I don't say like we're testing you for frailty. I
Right.
feel like one, people don't know what that means. Two, it's there's so much ageism. It's just very stigmatizing. So
it begins with an F, which doesn't sound good. Like I got an F on my exercise test or something. Great. This is perfect. Exactly what I wanted to cover. Sorry, we went a little bit long, and I'll get to the Q&A through text if we don't have enough time right now, but that we should start therapy with an integrase inhibitor unless there's some other issues. The weight gain is difficult to decide how to manage. Most elite controllers, I think we're leaning towards treatment, but as Dr. Cheever and others said, let's keep it individualized and let the patient weigh in. Don't change therapy in the setting of low viremia, but do look for drug-drug interactions and incorporate frailty and cognition as best you can into practice. And that's kind of the state of the art of where we are with 22 seconds over overall. So Dr. Cheever, I'll turn it back to you and let you use your judgment about how we want to move forward. It sounds like we're out of time, but thank you to the panel. Thank you to the audience for hanging in there with us. And sorry, I went a little bit over. But I did want to get to those last important things, and I'll address the questions.
Thank you so much.